in the last two chapters, we talked about the circulatory system and the blood system and the lymph system. And so in this chapter, which is the last one we're going to go over in summer quarter, we're going to talk about the cardiovascular system. So there's a ton of information in this chapter, and I'm going to try to hit the high points for you. So hopefully it won't be too much information, and a lot of it will be a review from your anatomy and physiology class. So we'll review the normal cardiovascular system, and then we will go on to talk about some cardiovascular disorders, which are very interesting. When I was working in acute care, I always loved working on the cardiac wing because interesting, exciting, scary, fantastic, amazing, wonderful, terrible things happen all in one day on the cardiovascular wing. So it's one of those anything can happen places, and most of it's good. Most of the time when we're working with people in physical therapy, we are getting them ready to go home. They had a cardiovascular event, or they had a mitral valve replacement, or they had a defibrillator implanted or a pacemaker implanted, and we're getting them ready to go home. So that is a wonderful thing to be involved in. Sometimes we get to see people at the end of their life in the cardiac ward. It's not always a good thing. One time I was working on the cardiovascular floor, and there was a man in his late 90s. I don't know why he was on the physical therapy caseload for that day. I mean, he obviously had therapy orders, but he had an ejection fraction of about 10%, and we'll talk later about what that means. Basically, his heart was not working very efficiently. He was kind of on his last legs, and I sort of peeked into his room, and I look in, and his whole family, his children and grandchildren and great-grandchildren and great-great-grandchildren are all in there with him. And I went up to the nurse and I said, you know, here's this guy, it's probably his last few days, his whole family's in there with him. I really do not want to drag him out of there and say, oh, well, I spent my last hour with the physical therapy assistant. I didn't spend my last hour with my family. So it was a kind of an awkward situation. And the nurse is pretty funny. She's worked in cardiac for a really long time. And she goes, I think it's just terrible. We just don't let people die anymore. And I said, oh yeah? I didn't know what to say to that. And she says, just let the poor man die gracefully, Don't drag him out of there. Don't do physical therapy with him. I'm like, okay. So I wrote a little note in the chart. But it's true. People are surviving with much more serious cardiovascular situations than ever before, and you see that sometimes in the hospital. So it's a pretty interesting place to be. The other interesting thing that I always liked is a lot of times right after open heart surgery, people are in the ICU ward, at least at my hospital, where I worked there in the ICU, and then as they get better, they go to the cardiac ward, and then they get to go home. And I always loved that walk from the ICU to the cardiac ward, like the person's improving. I'd show up to do their therapy treatment, and the nurse would say, oh, get the cardiac walker, let's walk over to the third floor. So we'd actually get the guy all hooked up to everything, and get the cardiac walker and walk over to the improved area. So that was always an exciting day. And usually that guy got to go home the next day. So nice things happen in the cardiovascular ward, and bad things happen, but it's always an exciting and interesting place to be. So the circulatory system, if we strip it down to its basic level, it's vessels, fluid, and a pump, right? And the vessels are the veins and arteries, and the fluid is blood, and the pump is the heart. So the blood flows from the systemic circulation to the pulmonary circulation, back to the systemic circulation, over and over and over again. At the beginning of chapter 12, there's a little figure in the book, and it's the path of an erythrocyte in the circulation. And basically it's goes from if we want to start at the left ventricle, let's just start there. It goes out through the aorta into the systemic circulation. It goes out to all these different organs and tissues, back to the veins, to the right atrium, into the right ventricle, out to the pulmonary circulation, gets more oxygen, back to the left atrium, into the left ventricle, back out through the aorta into the systemic circulation. For 120 days approximately, that erythrocyte is going to be doing its job going through that circulatory system until it finally ends up getting recycled in the spleen and other erythrocytes step in to do its job. So it's a closed system, it's a nice system, and when it works, it's great. And we'll talk about when it doesn't work later on. So the heart is the center of the cardiovascular system, and it's located in the mediastinum between the lungs, and it's enclosed in the double-walled pericardial sac. So the pericardial sac is made up of the parietal pericardium, which is a fibrous sac that anchors the heart to the diaphragm, and the inner sac is the visceral pericardium, or also known as the epicardium, which is a serous membrane that lubricates the inside of that pericardial sac to allow the heart to move. So that's really the job of the pericardial sac, is to facilitate those heart movements. The middle layer of the heart is the myocardium. That's made up of those specialized cardiac muscle cells. The cardiac muscle cells are interesting. They are specialized for that electrical activity that links them together to be to act as a whole. And so when I was reading an article on stem cell research, it was talking about when they're trying to differentiate stem cells into individual different types of cells. When they get the cardiac stem cells going, when they get a bunch of them together, they all beat in unison. So they don't even have a heart yet. They're not even a heart. They're just a group of cells, and they're already electrically linked. So that's a pretty cool feature of the myocardium. The endocardium is the endothelial lining of the inside of the heart. And the endocardium is what forms the inside of the chambers of the heart. It's the inner layer, and the heart valves are also made up of that endocardium. They separate the chambers of the heart and ensure the one-way flow of blood, so the valves keep backflow from happening. So the atrioventricular valves separate the atria from the ventricles. On the right side, it's the tricuspid valve that has 3 little leaflets or cusps, and on the left side, it's the mitral or the bicuspid valve with 2 little leaflets. The semilunar valves separate, they each have 3 cusps, and it's the aortic valve and the pulmonary valve, and they're located at the exits from the ventricles. So they're the ones that open up to let the blood either go out into the systemic or the pulmonary circulation. The septum is the tissue that separates the left and the right sides of the heart. So isn't it pretty? Nice little heart. It's a nice little organ system. Very fancy. So, excuse me, the heart conduction system. So any of those specialized cardiac cells can initiate impulses, but they don't most of the time. Usually the impulses are initiated at the sinoatrial node, which is often called the pacemaker of the heart. It's located on the wall of the right atrium. That sinoatrial node is what makes it possible to transplant a heart from one person to another. So the heart muscle fibers don't have neuromuscular innervation the same way that skeletal muscle fibers do. So with skeletal muscle fibers, in order to contract, they have to get a message from the central nervous system that comes down through the upper motor neuron, the lower motor neuron, comes to the neuromuscular junction and stimulates that muscle to contract. The heart doesn't have that. It's the sinoatrial node that stimulates the heart muscles to contract all together. So it has a basic rate that we call our normal sinus rhythm. That's approximately 70 beats per minute. We do have autonomic system fibers that innervate the sinoatrial node that can alter the heart rate, and circulating hormones in the blood, such as epinephrine, can also alter the heart rate. But it's not the same as skeletal muscles, so that's pretty interesting. So once the sinoatrial node generates that impulse, the impulses spread through the atrial conduction pathways, and they result in contraction of both atria. So when the atria contract, it pushes the blood through the atrioventricular nodes into the ventricles. Then the impulses arrive at the atrioventricular node, which is in the floor of the right atrium, right near the septum. It's the only anatomical connection between the atrial conduction system and the ventricular conduction system, that AV node. So there's a little delay in conduction at the AV node in order to allow the ventricles to completely fill up. And then the impulses continue to the ventricle through the AV bundle, or the atrioventricular bundle. It's also known as the bundle of His. The right and left bundle branches and the terminal Purkinje fibers stimulate the simultaneous contraction of the two ventricles, sending the blood either out into the aorta from the left ventricle or into the pulmonary circulation from the right ventricle. So the conduction of those impulses produces a change in electrical activity that we can detect using electrodes attached to the skin on the body surface, and that is called an electrocardiogram. So basically the electrocardiogram shows us a visual representation of the voltage in the heart over time, and this is a depiction of the normal electrocardiogram. So that first little blip is called the P wave, and it represents the depolarization of the atria in response to the sinoatrial node triggering that depolarization. There's a QRS wave, which is that big arch, big pointy arch, and that is the depolarization of the ventricles. And then there's a little blip on the right side, and that's called the T wave, which represents the repolarization of the ventricles. So in between the P wave and the QRS complex, there's the PR interval, and that depicts that delay of the atrioventricular node to allow the filling of the ventricles. And then there's a little flat portion between the QRS and a complex and the T wave, which is the beginning of ventricle repolarization, and it's usually flat. They call it the ST segment. So the heart is controlled by the rate of contraction is controlled by the sinoatrial node, but there's a cardiac control center in the medulla oblongata of the brain stem that controls the rate and force of contraction. So there are different things that influence that. We have nerve receptors that are called baroreceptors that detect changes in blood pressure in the aorta and the internal carotid arteries. So changes in blood pressure, that information is then relayed to the medulla, and it can adjust the rate and force of contraction of the heart. Sympathetic stimulation, the sympathetic nervous system is the fight or flight system. It can increase the heart rate, causing tachycardia, because when the sympathetic nervous system kicks in, it's the fight or flight response. We have to have that increased heart rate so we have blood going to our muscles so we can run or fight, I guess. The parasympathetic system, it's the rest and digest system. So activation of the vagus nerve, which is cranial nerve 10, by the parasympathetic system decreases the heart rate. That's our rest and digest. So there are different autonomic nervous system pathways that can control the heart rate as well. So lots of different factors can increase heart rate. Increased thyroid hormones or epinephrine, that can do it, and those are circulating in the blood. Elevated body temperature, like an infection, you have a fever, that can cause increased heart rate. Increased environmental temperature, particularly in high humidity. We're pumping more blood so we can circulate the blood and lose a little heat that way. Exertion or exercise, of course, can increase your heart rate. Smoking, another reason why smoking is not that good. A stress response, you're having one of those days at work, your heart rate might be a little bit higher. Pregnancy, because of course the heart has to work a little harder to push the blood through the new circulation that is helping the developing fetus. And pain can increase your heart rate because it stimulates that sympathetic response. So the coronary circulation is the first part, really, of the systemic circulation. So the cardiac muscle requires a constant supply of oxygen and nutrients to maintain that heart rate and conduct impulses and contract efficiently, but it doesn't really have any storage capacity for the oxygen. So there are two major arteries, the right and left coronary arteries, that branch right off of the aorta immediately above the aortic valve. So as soon as it leaves the heart band, it's going right to the coronary circulation. So it makes sense. I mean, that's an important thing, and it's got to keep that going. So the right and left arteries divide into separate branches. I'm not going to expect you to know the names of all the different branches of the coronary circulation. Suffice it to say that they both divide, and then there are all these different small branches that supply the myocardium and endocardium with circulation. And there's not, besides the coronary arteries, there's not much collateral circulation. So all of the blood supply for the heart is coming from the coronary circulation. That's just that same picture, bigger. So the cardiac cycle, it's just the different relaxation and contraction of the heart. So diastole is the relaxation of the myocardium, and that's required so the chambers can fill with blood. And systole is the contraction of the myocardium, and it provides that increase in pressure to eject the blood. So it starts out with, the cycle starts with the atria relaxed, filling with blood. The atrioventricular valves open, the blood flows into the ventricles, the atria contract, and the remaining blood is forced into the ventricles. The atria relax, the ventricles contract, and the AV valves close so you don't get backflow. The semilunar valves open, the blood goes into the aorta and the pulmonary artery, and then the ventricles relax. And then it starts again. The whole heart's relaxed, the atria fill with blood, AV valves open, blood flows into ventricles, etc., etc., etc. So the relaxation is important as the contraction. The relaxation is as important as the contraction for effective pumping of the heart. So the cardiac cycle, another depiction of it, the venous system returns blood to the right atrium, the venous flow arrives in the right ventricle, the venous blood is sent to the lung via the pulmonary artery. After oxygenation in the lung, the blood returns to the left atrium, the red blood arrives in the left ventricle, and then the red blood is sent in the arteries to the tissues. So, different way of thinking of it, but it's the same sequence. So the heart sounds are the opening and closing of the valves. Basically, it's the closing of the valves. So they call the normal sound, they call it lub-dub. And you listen to your heart, it's lub-dub, lub-dub, lub-dub. So the lub is the closure of the atrioventricular valves. So the blood is in the atria, it flows into the ventricles, and then lub, those valves close, so the ventricles can contract without backflow into the atria. And then the ventricles contract, send the blood out through the pulmonary artery and the aortic artery, and the dub is the close of the semilunar valves to keep the blood from flowing back into the ventricles. So when you get auscultation is one of the normal diagnostic tools for the heart, where you listen to with a stethoscope, and that normal lub-dub is what you're looking for. There's some other sounds that doctors are trained to listen for, doctors and nurses, and respiratory therapists, but we're going with your basic lub-dub with the heart, with the valves closing. Murmurs, it's sort of like glug 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 dub, glug 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 dub, or depending on which valve's involved, it's caused by incompetent valves, so there's a little bit of leakage in the valves, and you get sort of smeared heart sounds. Your pulse indicates your heart rate. It's how many times your heart is contracting in a minute. The pulse deficit is if there's a difference in the rate between apical and radial pulses. So pulses near the apex of your heart, and your radial pulse in your wrist. So sometimes that can indicate different blood flow issues. There's some different problems, and we'll talk a little bit about that later. So this is the same. It's just another depiction of the cardiac cycle, and it's talking about it's dividing it into diastole and systole. So when you're taking somebody's blood pressure, diastole is the lower number, the pressure when the heart is relaxing, the diastolic blood pressure. The systolic blood pressure is the higher number when the heart is contracting. So cardiac output is the volume of blood that's ejected by a ventricle in 1 minute, and it depends on the heart rate and the stroke volume. So it's basically how much blood by volume volume per minute is ejected in a single contraction, in a single minute of contracting ventricle. Boy, that was not good. So how much blood can the ventricle put out in a minute? That's what it means. So if you're at your normal sinus rhythm of 70 beats per minute, and that's your heart rate, then your stroke volume is how much the volume of blood times 70, right? That's your cardiac output. So that's how much blood is ejected by the ventricle in a minute. The preload is the amount of blood delivered to the heart by the venous return. So that the preload is in the atrium. The afterload is the force required to eject the blood from the ventricles. And so that's determined by peripheral resistance in the artery. So if there's more resistance because you have atherosclerosis, it's going to take more force to eject the blood from the ventricles. So that's why that can eventually cause hypertrophy of the heart, because more force is required. So the cardiac reserve, it refers to the ability of the heart to increase output in response to increased demand. So a healthier person is going to be able to increase their output if there's increased demand, like from exercise, for example. Um, and then, so they have more cardiac reserve. Somebody who's not as healthy has less cardiac reserve, if that makes sense. So this is just a little representation of cardiac output, amount of blood pumped by each ventricle in a minute, and the average is 4,900 to 5,000 milliliters, so that's a lot. 5 liters in a minute. That's good. That's good cardiac output right there. So factors affecting cardiac output can be the sympathetic nervous system. If your heart rate is up because you have a sympathetic response, things affecting stroke volume can be your venous return. If you have compromised venous return, you're not going to have as good a stroke volume because you don't have the preload. Your actual blood volume, your sympathetic nervous system, and the peripheral resistance, that afterload. So there's a lot that goes into cardiac output, but the normal the normal average is pretty high. So we have 5 liters of blood in general, we're talking about in the blood chapter. So in a minute, your heart can pump that whole 5 liters through. That's pretty cool, huh? So I said just a minute ago with your blood pressure, it's basically, it refers to the pressure of the blood against the systemic arterial walls. And so the distribution and structure of the various blood vessels we talked about in chapter 10, sort of the normal adult blood pressure is in the 120/70 range, and it's measured in millimeters of mercury at rest. The systolic pressure, it's the higher number. It's the pressure exerted on your arterial walls when the blood is ejected from the ventricles. So that's your higher number. The diastolic pressure is the pressure that's sustained in the vessels when the ventricles relax. So your blood pressure depends on cardiac output and peripheral resistance to blood flow. So when we start to talk about some of the different pathologies, you'll see how those can affect blood pressure. So normally the peripheral resistance can be altered by vasoconstriction or vasodilation of the arterioles. Systemic or widespread vasoconstriction occurs in response to sympathetic stimulation. So what happens is you get systemic vasoconstriction, your heart rate goes up, your blood pressure goes up, the blood is more available in an emergency, basically, with sympathetic activation, sympathetic stimulation. So systemic or general vasodilation leads to decreased blood pressure, either from reduced sympathetic stimulation or from increased parasympathetic stimulation. So any obstruction in the blood vessel increases the resistance, and that can increase your overall systemic blood pressure. So if you have arteriosclerosis or any kind of restriction, that can increase your blood pressure. I think that's all we're going to say about that. So increased output from the sympathetic branch of the autonomic nervous system causes increased vasoconstriction and increased blood pressure. Decreased sympathetic output is vasodilation and decreased blood pressure. So the blood pressure is directly proportional to your blood volume. A lot of the control of blood pressure is exerted by hormones. So the antidiuretic hormone, which we talked about in the fluid chapter, it increases water reabsorption through the kidney. so it increases your blood volume. Its other name besides antidiuretic hormone is called vasopressin, and it causes vasoconstriction. So it causes vasoconstriction and increased blood volume, so it increases your blood pressure. Aldosterone is an important control and compensation mechanism when there's a decrease in renal blood flow. And so when any decrease in renal blood flow stimulates the release of renin, which then activates angiotensin, which is a vasoconstrictor, and stimulates aldosterone secretion. Angiotensin 2, which is stimulated by aldosterone, is a powerful vasoconstrictor. So all of those things increase your blood pressure. The different force that those hormones exert. So some of the medications, we'll talk about this a little bit later as well, some of the medications used to treat high blood pressure are diuretics or ACE inhibitors, which affect that renin, angiotensin, aldosterone cycle, and they can keep your blood pressure lower.